We have questions. Doc, here, Ogilvie is 18.5% in mentally ill. May I ask, what are the most common psychiatric conditions associated with ACPO?
Well, unfortunately, I'm not able to answer that question. The studies only say that mental illness, they did not describe, at least not the ones that I was able to read up on. They did not describe what type of psychiatric illness will result in that. I think what's important to remember also is that it might not be strictly the type of psychiatric illness the patient might have, but it might also be related to whatever these patients have been ingesting, the medications that they're on. So it's not necessarily the psychiatric condition that is resulting in, or the type of psychiatric condition resulting in Ogilvie's. So there are a lot of things to consider for these patients.
Thank you for that, Doc. Okay, how prevalent is Ogilvie in the Philippines?
It's very rare. If you see that one case series, it was like 6 patients in a span of 3 years. And if you are able to remember what I described, there is like only 100 patients per 100,000 patients. I don't think this is exclusive to just Western countries. This probably is the same also in our country, where it's so rare. Again, about 100 per 100,000. So very, very rare. But, it's a missed opportunity, even if it's rare, missed opportunity for the intensivist or the clinician if they're not able to recognize the condition or know how to manage these patients once the patient is there in front of them.
Thank you for that, Doc. With regard to imaging, we know that abdominal X-ray is usually the first imaging of choice. So when is CT scan advisable? Because sometimes we have these patients in the ICU, they come in, they didn't really have, abdominal complaints to begin with, but develop suddenly abdominal distension or any hypomotility problems, so only while in the ICU or in the ventilator. So clearly, they only developed Ogilvie's within the hospital as a nosocomial, I think perhaps nosocomial complication. And sometimes it's so hard to bring them down to the CT scan.
Right. So I would say that it actually depends on, how urgent you need your test and your ability or your access to testing. CT scan is probably a good test to do, but it does take a while to get, the patient scheduled, get the patient into the CT scan department so that you can get an imaging study. And an X-ray is very easy. You can do it at bedside. I wouldn't encourage that you just choose only CT scan because even if CT scan could help clinch the diagnosis right away, there's some monitoring that still needs to be done for these patients, and you would need always a baseline X-ray of the abdomen anyway. So you might as well do it regardless of whether or not you eventually plan to do a CT.
Okay. Is there a hallmark regarding the size of the cecum suggestive of a colonic obstruction via an X-ray? Because I know that you mentioned earlier there's a cutoff size regarding.
Right. Yeah, no, that is just the size of the dilation of the cecum. So you can have a size bigger than that or even smaller than that if it is a mechanical cause. Right. So it doesn't have to be just Ogilvie's producing that size of a cecum. The 12 is just to warn you that when the cecum is that size already, you're at great risk for ischemia and perforation already. But whether it is pseudo obstruction or it is actual mechanical obstruction, I don't believe there is a particular hallmark so that you can make a diagnosis of one over the other. I think what you would look for, really, what's important to look for are transition points. So if you're not able to find transition points anywhere on your X-ray or your CT, right, then you would have a low probability or low possibility of having an actual mechanical obstruction. If it is all just dilated, then then it's probably a motility issue, right? Mm-hmm. But if there are areas or points along the course of the intestine where it narrows suddenly or there is a cutoff, then it would be important for you to rule out a mechanical obstruction.
Thank you. There's somebody asked about how many hours putting patient on an NPO basis on the first line as a first line of treatment.
Generally, it depends on the clinical situation. Like if your patient is improving, there's adequate decompression, and in your analysis, it appears like you can actually start feeding the patient, then you can do a slow feed, like you can do a drip feed or small bolus doses. In many of the studies, they claim that in about 4 days, an average of 4 to 5 days, the patients actually can already, if there is adequate decompression, you and the patient, hopefully in about 4 and 5 days, are already also better with regards to their underlying conditions, then you can start feeding them. So in general, about 4 to 5 days. But if the patient is still very sick, still tachypnic, he's septic, he has a bad pneumonia, you might want to reconsider postponing NGT feeding.
All right, thank you.
The world moves in real time. So should our healthcare technology. With information needed, decisions to make, and experience to share. Every second counts. Live integrated tele-ultrasound enables real-time communication, remote collaboration, confidence, knowledge, and learning. The first ever integrated tele-ultrasound collaborative platform. Philips Lumify. Integrated tele-ultrasound, powered by React's collaborative platform. Innovation and you, Philips.
When do we consider referring to our surgical friends?
Okay, here's what I would do. I would already have surgery on standby with me. I think, I guess you probably would agree that, it doesn't hurt to get a surgeon on standby, to have a surgeon already knowledgeable about the case of the patient. So if there are immediate concerns or immediate interventions that need to be done, the surgeon is well prepared and well aware of the situation. But again, if you follow the algorithm, it is when there is failure of neostigmine and failure of colonoscopic decompression that you will need a surgical referral.
And there's a question here is how is the prognosis post-surgery patients with Ogilvie syndrome?
The prognosis, well, because these are not patients who are considered to be very ill or sick, they actually have good prognosis. So the treatment will still follow the algorithms that were presented, but you would think that since these are not old, very sick, institutionalized patients, that you would expect recovery in these patients post-op.
Another question, can ACPO be initially diagnosed by a GI specialist as a functional GERD?
Of course,
Yes.
we're all human, people make mistakes. But here is where it really is important, especially for a GI specialist, to be able to recognize Ogilvie syndrome. You probably will allow, more mistakes with non-specialists. But as a specialist, it should be first in mind when you're presented with a patient who has severe abdominal distension, maybe difficulty breathing, some pain over the abdomen. This is something that all doctors, especially the GI specialists, should be aware of. But yes, of course, I wouldn't be surprised. There will still be some situations where the clinical situation or picture of the patient is not perfect as it would be or as it is defined for Ogilvie's, so that the doctor can still make a mistake. Yes. And in fact, GERD symptoms like burping might actually be part of the symptoms of the patient, because when you have severe colonic distension, the air also can move up to the small intestine, so that the small intestines are also distended. The stomach can also be distended. In one patient in that case series of Dr. Dumagpi in St. Luke's, in fact, one of the patients had a very dilated stomach. And so if this patient started burping or complaining of acid reflux symptoms, then, it would not be impossible or surprising. But it's important for you to not just focus on, what are really common disease conditions like GERD. You also need to consider, or a good clinician would be able to consider, more severe disorders or more severe forms of an ailment so that they don't miss them.
All right. Another question. I think this is last question. Is ACPO hereditary, or what is the common risk factor?
I don't think it is hereditary. None of the studies or the papers have mentioned anything about it being hereditary. If that were true, we would have familial conditions already that have been identified, but no, we don't have that. It varies depending on the illness of the patient, but it can be as high as, 2.5% for post-operative patients, maybe higher, like I said, and somebody already mentioned the 18.5 in mentally ill patients, maybe a little lower for cardiac OR patients, somewhere around that range, still not very common.
All right. I guess that's about it, Doc. Thank you. I want to thank Dr. Prodigalidad for that awesome presentation and taking all of these questions. Thank you, and stay safe, everyone.